front of you. That's better.
Okay.
Good.
Perfect.
That's better. Good.
Okay, let's make a start. I think we've got some people joining in. So we'll start. All right. So thanks everyone for attending this webinar. We've got Simon Lammy here with us, who's a senior registrar from Glasgow. But before we start, we'll just give you a brief overview of what SIGAF is. So it's the Surgery Interest Group of Africa. We are concerned and passionate about education, mentorship, and research. So in terms of educational content, if you can find us on the Medal app. We've produced several educational videos on that app that you can also access retrospectively to watch at your own leisure. And we have also been recognized by the Medal app as being exceptional educators as well. And in terms of research across the entirety of the surgical specialties represented in SIGAF, we have about over 30 research papers, either ongoing or published as well. So it's an excellent opportunity to get involved from that point of view as well. And in terms of mentorship, we've got senior registrars and consultants actively involved in each of our sub-communities. So please do get involved with that. Final thing to say, this webinar will also be recorded and will be available for you to stream retrospectively for those of you who turn in late. So I'll hand over to Hilary to just introduce Mr. Lammy, and then we'll take.
Hi everyone, I'm Hilary, and I'm a member of the SIGAF Neurosurgical Group, and I'm honored and humbled to introduce our speaker today, Mr. Simon Lammy, who is a neurosurgeon at the Queen Elizabeth University Hospital in Glasgow. I know he's very well published, has extensive experience with research, and has written a number of books also. And it's my honor to introduce him. I've also followed you, Mr. Lamy, for a while. I used to send you messages on Instagram then, and you encouraged me to keep pushing. You're one of the persons.
Right.
Yeah, I don't know if you remember that I did reach out to you some years ago, and you encouraged me to.
Back.
Yeah.
Good.
Yeah. So I'm honored and I'm humbled to be introducing you today, and I think I'll just hand it over to you to continue.
Okay, hi everyone. Thanks very much for the introduction. Thank Tommy for inviting me, and also thank you, Hilary, as well. So I don't know where everybody is based, but certainly I'm based in Scotland in the United Kingdom, and it's an honour to talk to you this Saturday morning. So I think what I try and do and approach this is give some background about myself, and then explore some options regarding research base. I notice there's chat as well. So if you can all type into chat where you're all from. I can see Kenya. If you just type away, where's everybody from? Just type in the chat, please. And while we're doing that, what I will do is, so with me, so yes, I am Simon Lammy, one of the ST8 neurosurgical registrars based at the Institute of Neurological Sciences in Glasgow. So I'm in my final year of neurosurgical training. I'm also doing a PhD. So my ST8 year will be across not 1 year, but at least 3. So I'm doing a PhD simultaneously to clinical work. So that changes the mix. My intention is to be an academic neurosurgeon, but still have a strong clinical emphasis regarding the day-to-day and operating. So if I go backwards in time, so I did a undergraduate degree in neuroscience at UCL, went to the medical school at UCL, was president of the Students' Union twice, got heavily involved in student politics, which was more of a distraction, but always had intentions to pursue neurosurgery. Did my junior doctor years up in Aberdeen. And then also from Aberdeen, did a year of core surgery in Edinburgh. And in Edinburgh, did some cardiothoracics and also plastics. And from then went to Oxford and did an academic general surgical training program in vascular and general surgery. And then finally got my neurosurgical training number on the 3rd attempt and moved back to Glasgow, where I wish to have my neurosurgical training, and been there since. So yes, I've published a few things in terms of across the spectrum of levels of evidence, and also written 2 books, which have been well used, I think, by students trying to sit their Part B of MRCS. So that's me in a nutshell. What I'd still say, the whole journey with the research for me is still a journey. There's no fixed destination in mind, and I would say that's the thing usually when it comes to these sorts of things. So I can see some of you from Kenya, Nigeria, from India. What I would say is, before we launch into this, why research? That's often a question used. And if you have any questions, please type them in the chat and I'll try and answer them as best as I can. And why get involved in research? So first of all, I take it most of you are doctors, intent to pursue surgery. Is that correct?
That's correct.
Okay,
that's correct.
Sorry?
Doctors
Yeah, that's correct. Yeah, so you can also unmute your microphones. I'm more than happy for this to be fully interactive as well. It's a Saturday morning, so by all means get involved. What you have to have clear in your head is why you're pursuing the surgical specialty you're doing first of all, right? That's the bread and butter of why you are doing the job you do. Research is an optional extra to that. Okay, it's not core and it's not compulsory. No, your job, like my job as a neurosurgeon, is to see patients, assess patients, manage patients, whether that's conservatively, medically, or surgically, become up to speed on operative interventions for patients, knowing how to understand an operation, execute an operation, and that's a journey and that's an apprenticeship in itself. That's my primary bread and butter. Research, ask yourself the question why you want to do research. So some people get involved in research because they feel without it, they will not get a training number in the surgical specialty. And that's true. But also bear in mind, if you just do research just for research's sake, you're going to produce poor quality research, which will always stick to you. So therefore, if you want to get involved, make sure you're doing it for the right reasons as well, even if it's just to secure a training post. Beyond that, if you want to get involved in research properly, it takes time. Just as much as it takes time to get involved in surgery to understand what an operation is, to assist a surgeon during the case, to do simple things such as closing a wound, first of all. That's what you're trusted to do first. Then gradually you may be trusted more to close instead of just skin, subcutaneous fat, or muscle. And then beyond that, you get trusted to make an incision. And then beyond that, to make an incision, to do an approach. And once you do the approach and a consultant surgeon or a registrar assesses your skills to do an approach and closure, then you may be given more time to then do part of the case, which is why you're there in the first place. Like, resect parts of a tumor or do parts of a dissection en route towards a tumor or an aneurysm or things like this. No one gives you things from the start. Why? Because you're incompetent, you're inexperienced, and you're not qualified to do an operation, something which you have no understanding of. And we've all been in situations when we're assisting a surgeon and we say, oh, we could easily do that. And the boss notices your bravado, slight arrogance, and then says, okay, take control. And within 3 or 4 seconds, you recognize you're significantly out of your depth. So that's the experience with surgery. Funnily enough, when it comes to research, we think research is something you can just easily do. It's not. It takes time to understand what the principles are, how you go about data collection, making things are robust, coherent, how to communicate a clear message to a disparate audience so everybody understands what you mean, with a clarity and cogency of communication. These things take time. They are not skills you can just learn overnight. So therefore, what I would suggest is, if I asked all of you a question, I don't know how many people have in the chat, why do you want to do research? If you can all just give a brief reason why. Unlock your microphones, feel free to talk. Is that okay, Tommy, to do?
The format might not allow them to do that, but they can certainly type in the chat. Yeah.
Yeah, if you can type on the chat then, why do you want to do research? You can type your reasons on the chat, please. Okay, if nobody wants to type your reasons on the chat, that's absolutely fine. So if I ask Hillary, being that you're co-convening this, why research for you?
I was actually typing in chat box. So for me, it's because it will make me a much more competitive candidate to apply for a residency spot. And also, I do have an interest in neuroscience, and I believe I want to contribute to the field in some way,
Okay.
shape, or form. Yeah.
So if there was no competition for a residency spot, would you do research?
I don't know, conflicted. I think so. I think so.
Yeah. So being honest, the majority of people who want to be involved in research do so for competition for jobs. Okay, what I'm trying to tease out from you is: are you prepared to do research, irrespective if there's any competition for jobs? Because that's a very different mindset. Doing research for competition for jobs is understandable, but once you get your residency post or neurosurgical training number or surgical training number, that interest in research drops. And the concern is that in the future, when it comes to new innovations in surgical practice or changing evidence base, people who do not have a genuine interest in research become quite deaf to new changes. Okay, so we've all worked with senior colleagues who, if you suggest a new way of doing things, which is backed up by 10 years of evidence, have a frank disregard for it because they've never had a genuine interest in research to begin with. So therefore, if you're on the latter group where you have a genuine interest in research, that's good. But it's something which is core to maybe getting a residency training number, but won't be influenced regardless whether you get one or not. And when you get one, you'll still continue in that research theme in the future and have a genuine interest. So first of all, I'd suggest all of you to do is to evaluate why you want to do research beyond getting a residency number. What aspects of research you're interested in? Is it lab-based? Is it clinical based? And those are the two parts that you need to be quite clear on. So a lab-based PhD is very difficult to do. It takes a lot more time to set up. You're dealing with margins which you can't just easily reproduce quickly. You know, the sort of basic science bench lab approach is very scientific, as we imagine scientists are. It involves lots of biochemistry, chemistry, physics, lots of maths. And experiments which you can set up across 6-7 months can fail in a heartbeat. Okay, so if you want to do a lab-based PhD, it's with the intention that you're going to run a laboratory in the future, and that's a very different underpinning. What's easier for us as doctors to understand is clinical-based PhDs or clinical-based research, and this often involves us looking at our workplace, looking at certain solutions to problems to fix, or trying to dream up new ways to treat, for example, malignancy being quite common, new surgical approaches or new techniques to use, or understanding on a population level why diseases occur in the first place and what we can do to try and mitigate that. And these things are not necessarily easier, but they are more straightforward to understand. So in your head, which of those two parts do you wish to pursue is the question. And then from that, how do you wish to go about and do it? So the next question people have is, how do I get involved in research? I don't know. If you're doing it just to get a training number, well, I'm sorry, there is no time. As in, it's too late. The research you get involved in is going to be poor quality and really is not going to make a genuine influence whether you get a training number or not. If you look at long-term planning with research, which is better, that takes years of investment. So for those of you who are quite junior to this then pays off in the end. And like most things in life, if you've got a research training application coming up in the next 12 months and now you'll suddenly get involved in research because you think it'll make a difference, it won't. I can guarantee that it won't. The research you'll produce will be poor quality and will be something which will not make that much of a difference. In comparison to that candidate who's been involved in research for 3-4 years, they're producing good quality, more likely to be published in higher impact medical journals, have more of an influence and more of a critique. So therefore, if you're leaving all of this to the last minute, my suggestion is not really to head, to dive straight into research themes, because it is too late. And what you produce is going to be poor. And if it's poor, that mud will stick to you and is not going to do any favors in the short, medium, or long term. But for those of you who do have a genuine interest, how do you get involved in research? So the question then is first of all, read. do you read the medical literature to begin with? Because many people want to get involved in research, do so, but more so that they expect someone to hold their hand, give them advice about what new groundbreaking systematic review, meta-analysis, or prospective cohort study they can dream up and pioneer to get involved in. And that's fine. But if you're not used to reading medical literature at all, which is the end product of research and the core of how things get critiqued and evaluated, how can you possibly have any idea about what questions to ask if you don't read the subject matter in your own discipline properly to begin with? So what I suggest is read. So we have the British Journal of Neurosurgery or World Neurosurgery or other neurosurgical journals. You have journals in every single surgical specialty you can find. Read. If you have a question, read. Read widely. Have people answered your question before? Have they published before? Go along to a few conferences, not to present, just to sit, watch, listen, observe, listen to who you're trying to engage with in the future. And that's good. People don't give this advice because it sounds like a lot of hard work. But like everything in life, hard work's important. So once you then read and you're used to reading and understanding, you can then formulate some questions. And then when you have a question, you then need to have someone senior to you to help you curate that question, to shape that question, to critique your question for several reasons. One, the question may be pointless, or if the question is good, that question may need help in order to attract the right sort of resources to optimize that question into research. And that's where you have senior people who can help. Okay, so this is the proper way to do it with you asking questions you wish to have answered. The alternative is not to do any of that. The alternative is simply just to knock on someone's door, as people do to me, and say, have you got anything I can be involved in project-wise, where somebody has no questions and has done no reading at all? That's fine. But then if you knock on my door like that, then my question is going to be, I've got a project. I expect you to read X, Y, and Z first to help you understand about the project before I let you get involved. So either way, you're going to have to do some reading, right? Once that's done, if you take the latter approach, you may want to get involved with some senior researchers and be quite humble in your expectations, because some people knock on my door thinking they want to run a project which I'm already doing. No. If you're going to get involved in a project, someone senior to you, be humble. You're going to get involved in data collection and collecting a lot of data. And some people don't often realize this. They want to be at the end of a process when they're more just writing things and analyzing results. Collecting data is extremely important for several reasons. One, it shows you the software platforms you've been involved in to extract data. And if it's more clinical research you're doing, that involves lots of different electronic platforms or going through patient notes in hard copy form, and these things take time. You then learn new skills and techniques in how to make not shortcuts for data, but shortcuts regarding time management skills, regarding how to optimize data quickly when you have limited time. Also, it teaches you the benefits of forming Excel spreadsheets for data collection properly and how you can access these, not just yourself quickly, but also someone senior to you or somebody else outside the project's looking at it, that they know exactly what's in your head and where you are going. And these things take time. So I've had a colleague recently who's asked me to collect some data for him. So he's no longer here in Glasgow, but yet his data collection sheet, there is no data collection sheet, there is no format, there is no logical step-based approach to this, which means it's very hard for me to figure out where to get data, how to do it. And to cut a long story short, I cannot complete this for him. That's an experience thing. So you learn techniques when you're involved in data collection with someone senior to you, especially do it properly, that if you were smacked by a bus, for example, tragically, and I'll know more, can someone look at your data sheets and be, I know what this person was doing, I can continue the project. And that's the whole point of data integrity and things like that. Also, honesty regarding data collection. If you do shortcuts with data, your results can be skewed significantly, and all it takes is for someone else to go, well, I'm in your same department, I've been looking at the same numbers, and there's 10 patients missing from that data set. 10 patients missing in a data of 100 is very significant. Okay, so that's what I suggest. But once, irrespective of the journeys you take, once you do start working with someone senior to you to answer specific questions, then there's some things you can do to help you. So there's in Britain, we have the NIHR, Good Clinical Practice, which you can access for free online. If you Google NIHR GCP, it's an online resource module which helps you just understand some of the real basics of data. Now, it's extremely basic. It's not going to teach you anything unique regarding how to get something published in the Lancet, but it's a core thing to do. It's a certificate which I insist on everyone who works with me, I insist that they do it. Because when you do it, it teaches you about honesty and research integrity. Because fundamentally, when I work with someone, I don't want them to take shortcuts. So I double check and triple check all the medical students who work with me. And if I pick up themes where someone is consistently missing data, which is readily there to access, or they've inputted data incorrectly, I dump them from projects. I give them advice. I suggest for them ways for them to recognize the errors, to help them through. But I've had occasions where I remember one individual, he did not see what he was doing was wrong. So I cut him loose, done, finished. He kicked up a massive stink over it. But no, just as much as I would not want to be a senior surgeon and have a junior surgical trainee who says to me, yes, I can do X, Y, Z. And it turns out time and time again in theatre, they cannot do what they have boasted they can do. That's dangerous. The same applies to research. Okay, so the GCP is good. At least it gives me an intention that somebody understands what honesty is in research, which is if they make a mistake, that's fine. But then again, if they keep making mistakes and lack insight or lie about it, especially if they've got that certificate to their name, I can benchmark them and go back to them and say, hang on a second, what's going on here? So GCP is good. You've got ones from the National Institutes of Health in the States, which is also very good to do as well. But those are basic things. Other things to do if you want to get involved in research is work out what you wish to do. So you have the levels of evidence in research. And if you think along clinical research themes, not lab-based, the highest tier is systematic reviews and meta-analyses of homogeneous data. As you are systematizing and analyzing data sets of, generally speaking, prospective, blinded, randomized controlled trials where the data is quite strict. The inclusion criteria is strict, the exclusion criteria is strict, which means across multiple data sets and studies published, you've got homogeneity across that. The downside with homogeneity doesn't often reflect real-world data, where patients don't just come in specific boxes all the time. But that's the highest levels of evidence. And then, of course, you've got systematic reviews, meta-analysis of non-homogeneous data. Then, of course, you've got your cohort studies, which can be homogeneous or non-homogeneous. And then, of course, you've got your case series, and you've got your letters and your expert editorials and books. Books, for example, are not the highest tier of levels of evidence, because it's often communicating knowledge already known over time, which is unquestionable. For example, your fifth nerve anatomical course is fixed, is done, and that's in the book. Okay, so what you may wish to do, and this comes into your reading, is to read widely again. And what's a letter? Do you guys read any papers for you to write a letter to critique something? This is a very useful thing to get involved with. I did this first of all. Can you read a paper? Can you critique it? Can you then write a letter to a journal about what your opinions are and back that up with evidence? That's quite useful. It gets you involved in the interaction with journals, the editorial process. And if you're medical students, it's a lot easier to have a letter accepted than if you're a senior consultant. Why? Because the standard expected from you is a lot lower. And also it makes the journals look good if they do publish things from medical students every now and again. It doesn't mean that they're going to accept any old rubbish, but they can be kinder, more sympathetic and more encouraging to help you have a letter published. And that helps with the process of you understanding the levels of evidence. Case series are something which is straightforward to do, often retrospective case series. For example, you may wish to analyze in your department the risk of death or serious morbidity in head injured patients who have been managed for the past 12 months. So all you need to go through is all the patients being admitted to a unit with head injury for the past 12 months, categorize them called mild, moderate, severe, categorize them into conservatively managed, medically managed, surgically managed, and then go through the data regarding outcomes, dead or alive, and split those things according to age, mean, range, gender, the type of head injury, mild, moderate, severe, the type of intervention, conservative, medical, surgical, the type of underlying pathology involved, any other associated injuries, and you can publish that. And you can publish it according to certain guidelines where people manage according to certain things. And this isn't necessarily an audit, but this is the easiest things to do. So I'll give you an example. In Glasgow, we analysed at 10 years and 15 years our decompressive craniectomies for malignant MCA infarction. Both been published. Retrospective, made sure there was complete data capture, going through every single craniotomy for 10 years. That's quite time intensive to make sure patients who are decompressed for MCA infarction are included. But you'll be amazed that documentation can be quite poor with retrospectives. On the clinical notes, on the operative note, there's the theatre logbook, the theatre nursing staff document, and you can come across craniotomy for extradural, craniotomy for malignant MCA infarction, craniotomy for brain bleed in the same patient, even though it's a craniotomy, decompressive for malignant MCA infarction. So it teaches you all these things. Okay, so that's easy for us to know. Another suggestion for a cohort study, oftentimes a prospective, is if you want to look at, as an example, add rates of disadvantages of high-dose dexamethasone prescribing in neurosurgical patients who have a tumour. And you may wish to start for 12 months and analyse all the negative consequences of patients being on steroids. And you've got your cohort, tumour patients, you have your inclusion and exclusion criteria, and you make that quite strict. And then you may work up to a randomised controlled clinical trial, or you may decide to do a systematic review of trials already published, provided, of course, that systematic review has not already been done. And that's generally what you may wish to get involved in. So enough of me. Are there any questions at all?
Yeah, we have some questions. One question is it possible to do research from Kenya with doctors in the UK?
So you can, but you may not gain access to patient data because you're not in the same trust. So I get emails from people all across the world saying, can I be involved in your projects? Well, the answer is no, because if it involves patient data, I cannot send you that data to analyze. That's wrong on so many levels. It's individual patient data. Generally speaking, it needs to be people involved in the, not just day-to-day management of the patient, ideally employed by the trust where their permission's already given. However, ways you can get involved in is if someone is doing a systematic review of data which is already published, then you can. The question is, how do you contact someone in Britain to get involved in data like that? And it's hard. What I would suggest is this myth, for those of you outside of Britain, that everything in the United Kingdom is fantastic, is not necessarily true. You do have resources to hand where you are, okay? Because I know some of you may want to get involved in research in Britain, but you think if you have Britain involved in your CV, that's going to necessarily improve your odds. I'm sure it would, but it's not entirely necessary. So therefore, if you ask that question, can I get involved with research in Britain? Full stop. The answer is yes, but you need to be more detailed with your question. If your question is, I have an interest into infection rates in split thickness skin grafts, and I've been looking at something where I work, is there anybody else in Britain I can work with where I can compare and contrast the rates of split thickness skin graft infections where I am to split thickness skin graft infections, for example, in Coventry? Then that's a better question. So if you just throw out the question, can I get involved with research in Britain? That's not a good question. Okay? And no one who's ever just thrown out a question like that has had anything back. The overwhelming majority of people have had no help. However, if you look where you are and you walk around the wards and you say, I've noticed that we have a much higher rate of infection from certain types of skin grafts, I would like to compare and contrast these two infection rates of certain skin grafts in Coventry, then that's better. You can contact a plastic surgeon in Coventry or Brighton or somewhere else, ask the question, you do the research where you are, they do the research where they are, you go through your respective ethics approval boards, and then you get permission to cross-collaborate and compare and contrast your data sets and publish that. The title is a comparative analysis of infection following split thickness skin grafts in Coventry and Kenya. That's now a much better question and is more achievable because it's very specific. So I've just dreamed that up on the spot, given that away for free. All right. Now that reflects on the experience I've got, because I too was that person who used to go knocking on the doors going, can I get involved in research? No one answered, no one opened the door, right? Can I get involved in research? No one opened the door. It was fortunately when I got involved in research with MCA infarction and decompressive craniectomies, because when I moved to Glasgow, when senior consultant was having difficulties with his senior registrar at the time with the data, I came hungry, having published a few things, and then said, I'm involved in managing data sets. And he asked me to take control of the data set to such an extent that I booted the senior registrar off being first author because he was useless. And then I ran it, became first author on 1-2 publications on it. But that's more because of the skill set I brought. And then when I got involved in data management before, it was because I was happy just to process data for other consultants in different departments where I'd sit down and just literally collect data for them. That was it. And I learned how to manage an Excel spreadsheet properly. So by all means, you can get involved in research in Britain, but that's an example of how you need to be real specific with your question. Any other questions?
There's one question in the chat, Mr. Lammy, but I just had a follow-up question for you, maybe two. Obviously, in the UK, there's a lot of emphasis on doing audits, service evaluations. Yeah. How do you move away from a mindset of, because obviously, like some of the things you mentioned about, particularly retrospective case series, etc. In a particular mindset, you can view that just purely as a service evaluation or audit, right? So how do you move past that and think about it more as a research opportunity or research question?
Yeah. So first of all, don't just get involved in. Look, I don't know how it is overseas, but in Britain, juniors are expected to do audits to an extent where every junior doctor has to do an audit just to be signed off for basic parts of training, and that's a waste of everyone's time, because then everybody does stupid audits, such as, and I did one which was quite stupid too, coagulation screens in patients who are not on anticoagulants, who are undergoing spinal neurosurgery. We all know if not on an anticoagulant, that coagulation screen is going to be normal in 99.9999% of all patients. It's proven every single year by every single junior who does this, but we still insist on a coagulation screen even though somebody's not on an anticoagulant, right? So audits like that are genuinely a waste of people's time. Audits, if done properly, should change practice. So I give an example of one of our very good FY2s years ago is now an ST3 in general surgery in London. Very, very good. She used to analyse some of our operative notes and recognise how poor they were to help juniors understand what was done, the indication, the intention of the operation, and the post-op plan. So some operative notes, you analyse them, just say craniotomy for tumour. That's it. Standard approach, tumour resected, closure. What's the indication? Patients 35 had seizures for 3-4 years, disabling 2 or 3 a day, is now on triple anti-epileptic medication. It's been discussed that the epilepsy MDT has a detailed MRI imaging, including SPECT imaging, ictal, interictal EEG. That's more specific and helps the junior, ironically, understand more about the patient than us talking to the junior. So she analysed this. She came up with a whole list of things from the first cycle of going over 100 patients. And she tried to benchmark it according to established standards from the Royal College of Surgeons of England. We were deficient in almost every single category. We didn't even state sometimes the date or the time of the operation on the op note in some cases. She presented it to the department. She then reordered it 100 cases later at a specified time. There was a statistically significant improvement, which is still the case in the department. We put up posters everywhere. It got published in the British Journal of Neurosurgery. It has changed practice, albeit it's changed practice gradually. And then it got discussed at Council of the Society of British Neurological Surgeons whether we should have a templated operative note for certain neurosurgical procedures. Not all, but some, like microdiscs. Things which are high volume, easily reproducible. And of course, many people discussed it and said no, and that just reflects the very individual nature of neurosurgery. But in general surgery and orthopedics, they have templated operative notes specifically because for the medical legal consequences, right? Neurosurgery hasn't quite caught up with that yet. So that's an example of a good audit. It's probably the best one I've been involved in and makes sense. So therefore, if you want to do an audit, make sure you can find a standard which your department does not adhere to, a national or international standard, and then make sure you complete cycle 1 and cycle 2 of the audit involved, right? The setup for these things takes time. So how long you spend in your setup thinking about the question, how you're going to go about data collection, how you're going to go about storing that data, the people you're going to be involved, you be very clear and very careful you involve, and the consultants too. You may spend 6 or 7 months on this properly before you even start a single data collection point. Because the longer you spend on that run up, what you don't want to do is then hit data collection and then go, 3 months later, we've missed this, we've missed that, we've missed this, we have to go back again to the notes, Because when you're doing that, it can be argued you're looking for things to help you answer your question in the way you want it to be answered. And then that comes across wrong. So how long you set up with your methods properly dictates the success of any project. Because when you collect the data and analyze it, that becomes a more straightforward part of all of this. Any other questions?
Hillary, you're not coming through, so I might just take the next one. There's one more question in the chat, Simon. But before I do that one, just going back to that doctor asking, how can I get involved in research from Kenya? And then you're saying, okay, obviously come with a clear question. But the other thing is, so what if that doctor's in Kenya and there's not a strong research, culture in their department? They don't have consultants or supervisors or mentors who are willing to, do you know what I mean, take that project forward. What sort of advice would you give that kind of person?
Yes, that's very difficult. And there are junior doctors in Britain who are stuck in hospitals. There's no strong research lead. What I would say is extremely difficult if you're somewhere where there's no one interested in research to help you when you're very junior, when you're clueless about research. And that has been my experience in some places. It's actually extremely difficult. Reading comes into this, reading what people publish, how to go about things, and that can take some time, but you do need some direction. And if you genuinely are in a place where there's no one there who can help you give any advice, because it's quite a new world to be involved in research, and my suggestion is to move. You may have no choice. You may have absolutely no choice. That doesn't mean move to Britain. No, move somewhere local within Kenya or surrounding countries in Kenya where there are people. It could be even a hospital where there's one lone individual who's publishing something once every 5 years, but at least they are on the money, understanding what research is, or asked to do an elective in a place which is research intensive. So you may be in Kenya and think, actually, let me come to Britain and do an elective for about 8 weeks, not to see patients, not to operate, but specifically to do a research elective where there's a clear, definable research project where somebody in Britain is prepared for you to come across and do, finish, then go home. And then when you're doing that elective, you then gain some understanding and skills. But that is a research elective. That's not being in theatre, it's not operating, it's not seeing patients. It's very specific, just as how hard it is to learn medicine and to do surgeries or any branch of clinical medicine. Research, if you're new to it, has to be as focused as well, if not more so, because you don't have many people talking about it. You don't have many people to sound off ideas from. So that's what my suggestion would be. If you're genuinely stuck somewhere where there's nothing, you have to move.
All right, Mr. Lamy, I don't know if you can hear me now.
Yes.
Okay. So I have a question now. I once had a mentor tell me that because I'm currently in final year in medical school, and he was of the opinion that I should spend the time in medical school focusing on becoming a competent doctor and maybe leave pursuing research till when you're done, because it can be very, like, he believes like doing good research takes time, and like you have very limited time as a medical student to even build your knowledge base competencies that would help your clinical, like becoming competent as a doctor first. So I don't know what your opinion is. Is it like should you separate becoming competent as a doctor than doing spare time for research or working hand in hand at the same time?
So this depends on who you are and how good you are. Let's be quite honest here. There's some people who are excellent in medical school, who are so bright, they are always going to get the prizes, and they can do research projects simultaneously. They're few and far between. Most people can't do both. What you do not wish to do is where you finish medical school with papers published to your name, but where you're thoroughly incompetent to understand the basics of treating diabetic ketoacidosis, treating an asthmatic exacerbation, treating a myocardial infarction, examining someone's leg for a DVT, distinguishing between radicular pain or vascular claudication. Okay, these things are extremely important, because when you do start as a doctor, your primary role is as a doctor. You're employed as a doctor. You went to medical school to learn to become a doctor. You did not go to medical school to learn to become a researcher. Two are very different. So given a choice, I would emphasize in med school, and I do sometimes reject more medical students than I accept, because, give an example, I've had an experience recently with one first-year medical student who, before getting into medical school, had bought some surgical membership books and was trying to study these. That makes no sense. This is someone who's looking at surgical exams you sit after medical school, trying to read it before he's gotten into medical school, when he's not even learnt the basics of anatomy for your chest and abdomen, how to manage basic respiratory diseases, basic cardiology. It makes absolutely no sense. Okay, and he wants to be involved in research already, and I've had to say to him, no. You're now in first year, those surgical books put to one side, learn the basics of what preclinical medicine is, learn the basics of clinical medicine, then come back to me. I'm actually not interested. This same person has contacted several significant academics in England, and they have all emailed him back and then CC'd me in, because they know I'm in Glasgow, and said, touch base with Simon Lammy because he'll help you, of which my response has been, we've already been in touch and this advice I've already given. Then they've emailed him back and said, totally agree with your plan, Simon. In fact, this doesn't make any sense. Someone so junior, been so committed to want to do research when they've not even spent a year, 2 years, 3 years learning basics of clinical medicine makes no sense. Your job is to be a doctor, is to do no harm to patients. And that takes years to learn properly. So that would be my first suggestion first. So when I moved to Aberdeen to be a junior doctor, I was in a new city, 400 miles away from home, had to make new friends. I was in a very busy liver and gastro ward, very, very sick patients. Aberdeen is one of the highest rates of alcoholism in the United Kingdom or Europe. So it's very sick patients. For the first 8 months in Aberdeen, I did not read a single research paper. I did not attend a single conference. I did not write anything. Why? I was being a doctor for the literal first time. I had to get it right. I had to learn how you assess patients, treat patients properly, how you organize yourself in a ward. When you come to the ward in the morning, how do you organize bloods folder, imaging folder? Who do you prioritize for all the bloods on that day? How do you manage someone suddenly having a cardiac arrest in the ward? How do you manage talking to family relatives and updating them? How do you request investigations? To learn the tricks of the trade, that when you're requesting a CT, it's not just to request it on the computer, it's to walk down to CT and talk to the radiologist. When you're junior and the senior says to you, order a CT on this patient, that's often it. Even if they explain it to you, once they walk away, you've got so many jobs, your page is going off all the time. When you request that CT, you've forgotten why. Also, even if you remembered why, you don't know the indication properly for the CT. Therefore, you don't write it down properly in the request. It gets rejected by the radiologist. This goes to and fro for 4 hours. You get frustrated. Then your senior has to be called to get involved, makes you look stupid. It's the basics of the job. It's learning how the job works. That is not something you can shortchange by some juniors who start work as a doctor first of all, and you can't see them for an hour or two because they're busy trying to do some research. Nurses can't get hold of them, right? No. Your first duty is to be a good doctor. I'd always emphasize that. Then once you get used to being a doctor properly, then you can start knowing what sort of questions to ask in the right way. Because how can you ask questions about disease conditions you've got no experience of? How can you interrogate the research base on scenarios you've had no experience of or you're thoroughly incompetent to begin with? Does all that make sense? It sounds very harsh, so what you'll see is that in Britain we have a model where some people can do a PhD within med school, and nearly 99% of people who do a PhD in med school don't do any research in that PhD once they qualify as a doctor ever again. It's just a PhD. They've got a PhD, it looks fantastic on their CV, on their email signatures, but most of them don't do any research, don't publish anything, attend any conferences or to research meetings. It's useless. So give yourself a bit of time to be a good doctor first, because the more time you spend and invest, the more space you have in your head regarding what questions you need to ask. That'll be my advice.
Thank you very much, Reza.
There's some questions here about what considerations people need to make about quantitative research from an ethical perspective. And then the question is, will you say that is a great impediment to research? So just to answer that question, if you do research without any ethical considerations, journals will throw that research straight in the bin, right? You need to have ethics in place. So the reason why it protects the patient, but also protects you as well. So the whole point of the process is to ensure measures in place to ensure the integrity of the research communication. Sorry, there's a lot of noise in the background.
Hillary, can you mute yourself, please?
So just to say that when it works with the ethics side to this is before anybody could just publish research. And the classic example is Wakefield's paper on MMR and autism, which if you read the original paper is rubbish. Read it, make your own conclusions. But if that went through a proper ethics panel first, it would have been probably critiqued before it's published and been pulled. So bad research often has no ethical oversight. The whole point of ethics is to make sure your question makes sense, the research is achievable, and that you have proper structures and systems in place. So now even for a case report to be published, you must have patient consent. That's ethics. Otherwise, anybody could just publish anything about a human being without asking that patient first of all, and that breaches that patient's human rights. You need to ask them first of all before you publish and print a devastating disease process which they've been through. So the ethics is important. If you want to do a case series, you should ask your trust first for several reasons, not just reasons stated, but when you publish something, your hospital's name is attached to that paper. So you're more or less saying you are doing this research in the name of the trust. If the trust's ethics board is not aware that you're doing this and it's published it, they can take you to court. It's that simple. So you need to make sure they know, you involve them. And if you have a history with your ethics panel, knowing that here's Dr. such and such, who is clear, communicative, involves us in good research questions, they are more likely to trust you the next time when you need more significant research to be approved in a shorter time span. So when you come in the future and say, I've got this good research question, but I've got a short space of time, can you please turn an ethics application quickly? They'll do so for you. If they know you've got a good track record of involving them and delivering your promises and publishing in a timely manner. If you don't, and they discover you've published something in the future and it gets questioned by somebody like me, because I think the research is shoddy, and I can always write a letter to your hospital's board and say, was this approved by your ethics panel? And they say no. Do you see what the problem is? So oftentimes you hear senior surgeons say, don't involve ethics. It's a waste of time. They just delay. That's often said by people who do not have a research history, have not published widely, have no understanding of the process involved, and frankly do not care about the consequences if the research is poor, shoddy, and someone talks to your ethics panel. So I'd always advise to contact your ethics board first. In Britain, we have the Call to Court Guardian, or we have the IRAS application form for studies to do. You also have guidelines online. So for systematic reviews, you've got PRISMA. For cohort studies and case control studies, and also case series, you've got your strobe consort statement. And even for case reports, you've got your care statement as well, about the framework you should function in when you are doing research for the different studies you wish to do. I hope that answers that question.
Perfect. Thank you so much, Mr. Lammy. I have another question for you, if you wouldn't mind answering.
Yeah,
So,
of course.
obviously, I'm doing a master's right now.
Yeah.
Obviously, interested. I wanted to deepen my understanding of stats and just my general confidence when doing research. As one of the reasons for doing it. But what would you say to somebody who maybe doesn't have the financial capability or to pursue, an academic degree, and they wanted to deepen their confidence into research? And would you say is it necessary to do a degree to take part in research?
So it's not necessary to answer the second question first. So it's not necessary to do a degree. You hear people say, "I want to do a PhD to understand research." That's one of the most stupid things I've ever heard in my entire life. Right? You do get people who waste so much public funding, university time, and just waste time doing PhDs because they just want to understand how research works. Look, I'm on my PhD just now, and it's a learning process. But before doing my PhD, I published 60 papers. You don't have to be that extreme. My point is, you don't need to do masters or PhDs in order to understand research. If you do genuinely want time and space to answer questions properly in a context of support and university environment, and you wish to then continue that afterwards, by all means, you have to do a master's and you have to do a PhD. That's common sense. But my point is, you don't need to go down a formal academic route to understand research. When it comes to statistics, yes, university modules can be useful, but what you'll find, university modules just gloss over. They give you an overview of certain aspects of statistics. They do not insert in your brain how to understand it. So, for example, take surgery. You can be in lectures all day long about how to open up someone's head. Unless you're in theatre and you're baptised and drenched in it, opening someone's head or watching it, observing it, doing it yourself for at least 12 months, you have no idea how to open someone's head. I don't care how many lectures you've sat in, how many 3D videos you've watched, how much of the Neurosurgical Atlas you've been watching. It means nothing to me. It means nothing to the patient. You have to be in theatre yourself. And statistics is the same. And coming back to what I said earlier on, you have to read. And reading is, there are no shortcuts here of research. What I want all of you to understand is, if you're thinking there's a shortcut to research and I can just quickly patch things together, I've done this. No, there's no shortcut here. If you want to write up a case report, it takes time, diligence, focus, to make it concise, to communicate it clearly. You want to hire tiers of research, it takes time. The statistics takes time. So what I advise is to read. And books I can advise are Medical Statistics Made Easy. Medical Statistics Made Easy. These days, I should not advocate this. For those of you who use PDFs without the author's permission, that is criminal. I want to make that clear. However, in the 21st century, PDFs are quite useful. You can have them on your phone, on your iPad, on your tablets, anywhere. So these days, try and get some of the PDFs legally and use these. So Medical Statistics Made Easy is brilliant. It starts off with the basics. What's a P number? What's a mean? What's the mode? What's the range? And some of you may say, oh yeah, I know what those things mean. If I asked you all individually right now, I can guarantee you most of you wouldn't. Okay, because every year I have to sit down and read this book myself every year. What's odds ratios? What's risk ratios? What does odds mean? What does risk mean? In what situations and papers would you use these on? What's significant? Highly significant, very highly significant mean? What's variance? What's covariance? Okay, these things are quite important. What's Kaplan-Meier for survival? What's your, standard deviation, standard error? What does normally distributed mean? And what tests would you use for that? What's parametric data? What's non-parametric data? What's nominal, categorical? The list goes on, right? So you need a book which clearly explains these things simply. When you understand these, they do give worked examples. And this book, Medical Statistics Made Easy, is fantastic for me. In fact, at the time of the year, I have to read it again to understand, because sometimes, unless you're living and breathing research, if somebody says categorical or nominal, a bit confused. And you can be on the masters, still get your masters, even in some cases still get a PhD, and still not know what these mean. And what you'll see from the real thoroughbreds in research, they know these things backwards. Just like when you look at surgeons at the top of their game, they know some of the anatomy backwards. The basics they know well. I'm not talking about the complex aspects of statistics, but the basics know well. So medical statistics made easy you can use. There are also free resources online, I think through the University of Oxford, which you may need to search. Most universities have got, Edinburgh is very good at having a basic tutorial on systematic reviews. But once again, you're reading, the easiest way to understand these things with data is to read papers published. If you read a systematic review, read their data sets. Look how they arrived at their analysis. How did they go through their Prisma flowchart diagram? That's the easiest way to know. Email authors and say, I'm doing a systematic review on this. I see from yours you did it this way. Why do you do it like that? I'm struggling to do it like this. Would you suggest? Okay. How that answers that question?
Yeah, very much so. Thank you. Just maybe a follow-up question from that. Would you? I guess it's important for you to be able to understand the stats yourself and to interpret the data, etc. But would you ever involve maybe like a dedicated statistician from a university, or would you do it all yourself?
Yeah, so when you start to get involved in more detailed projects, you do need to have a statistician. But do bear in mind, a lot of statisticians are not medical statisticians. A medical statistician is very, very different. Statistics is a broad church. Statistics could mean being an economic statistician, which is a completely different world. You're dealing with pound coins and pence. It's very different. If you think of people actuaries and accountants, that's a very different branch of learning entirely. So medical statistics need to be quite specific and make sure. So I had a project which I did. It's published now last summer, and this time last year I emailed the University of Glasgow and I spoke to about 4 or 5 statisticians, and they had no idea how to help me. I finally came across one statistician, and it's only because she's got an interest in medical statistics that she got involved. And to cut a long story short, she said, just do descriptive statistics. Now, that's very good and very helpful, and she curated some of the discussion. But, I effectively had already done descriptive statistics, but she was very good at sharpening that up. So what you'll find is that a lot of statisticians, you need to be very, very careful and very, very specific. There's been people who are medical statisticians really intimately aware of the levels of evidence specific to medical and surgical practice, and they're not easy to find.
Thank you, Mr. Lammy. I'm just trying to see if there are any other questions from the audience in the chat, but no one's posted anything. Can you see anything, Hillary?
I cannot. I'm going through it too.
I can't see anything myself.
Okay. Right. Yeah, maybe we'll give it 1 or 2 more minutes, and if there are no further questions, then we'll maybe just call it there. And thanks so much for doing this.
Yeah, Mr. Lammy, thank you so much. I really benefited from this.
Oh, okay. Yeah. We've got one question. So Daya couldn't be here. He's on call, but he's the assistant lead for SIGAF Neurosurgery. But he's asking, how do you decide on a specific research area of interest? I don't know if you touched on this earlier.
Yeah, so like most things in life, if you think of a specialty, why choose neurosurgery, vascular surgery, general? And if a student says, or junior doctor says, I don't know what to do, I ask them, if you open a textbook, you're stuck on a desert island, and you're given one chapter of the Oxford textbook of clinical medicine to take with you, which one would you take? And you're generally more likely to take one that you have an interest in, right? So when it comes to a research question, it is even more difficult. So therefore, my question to you would be, when it comes to a research question, why do you want to do research? And we have gone over that. It's important. And if you're sitting there going, I want to do research, but I've got a question, but I don't know what question, you're never going to have an answer, right? So one thing to do is to look at your place of work. And this is where the experience comes in. We're saying with Hillary, if you're a student who's not finished med school, but you've got no understanding of clinical medicine, to be quite frank, no experience of being on the ward properly with the responsibility that doctors have, you lack any insight to generate a question. So therefore, you're just asking a question to say, I want to do research. How can I get involved? That's like somebody who has never ever been involved in car racing, who barely knows how to drive a car, saying, what's the best type of car for me to drive, I don't know, for some pursuit they have that they can't quite quantify. You do need to quantify that. Sometimes get some experience of what you're in first. If you enjoy neurosurgery and you find that you enjoy CSF or shunts, then that's going to be a logical step to begin your question. If you like tumours or aneurysms, then get more experience of being around tumour or aneurysm surgeons and then asking them questions about the disease condition, because then they may throw a question back to you, which then forces you to think. Then based on you thinking, you go,
I think it's just a lost connection.
Yeah, we'll just give him a few minutes to reconnect.
Okay.
We still have time, don't we?
clinical experience, hang around more of the type of doctors and surgeons you wish to be, listen to what they say and how they talk and communicate things. And over time, when you do that enough, you will then start to develop a question that they can help you answer, which leads then to a more definitive question with research. I hope that makes sense.
Yes, it does, absolutely.
Yeah, we have a follow-up question on a point you made earlier on, Simon. So it said, I think you were emphasizing that medical students should learn medicine very well before doing research. So the question is, how do you maintain your clinical knowledge while taking a research year or gap year, if you want to optimize learning research?
Yeah, so what you'll see is many people, when they're doctors, then take time out to do a master's or to do a PhD. This entirely depends when you do start to take those times out. So you do find many people who are very junior who then go and do a PhD when they are very new to a specialty. So you get some people who do research when they've just gotten into neurosurgery, which means they know nothing about neurosurgery, nothing about clinical neurosurgery, operative neurosurgery, imaging aspects of neurosurgery, and they're going to do a PhD in something. And once again, they finish that PhD, come back to neurosurgical practice and do no more research ever again. Why? Because they then find out that learning neurosurgery is extremely difficult and very hard and requires all your time and focus. So I would suggest is you need to think why you want to take a year out. If it's to gain some genuine research interest for a question you have at that point, that's fine. You then have to accept you are not going to be richer in your clinical experience at the end of that year compared to when you started. In fact, you'll be poorer. So if you take someone who's done a PhD for 3 years, they are never going to be as good at operating as they were 3 years before that. And that's just tough. There's no really way around that. People try and be on call every now and again through a PhD. That's good. But if you're very junior doing a PhD to begin with, it means you've not really gained a lot of experience being on call. So when you're on call during a PhD, you're still really, really learning how to manage an on-call and how to do the basics of basic operating. If you go later like me, much later towards the end of training, you've gained a significant level of experience of neurosurgical practice. I've done my exams, which means that when I go and do an on-call now, I'm really well versed and familiar with what I'm doing anyway. So I've been doing neurosurgery now for 8 years. So it depends where you go, what timings are when you go to do research years. You have to accept sometimes if you go and do a research year when you're very, very junior, when your level of the specialty is very small and infantile, that actually by doing a research year, you've put a pause on your experiences of clinical medicine at that point. So it's up to you. My advice would be to get into a specialty of your choice, understand it properly, work extremely hard in it, and then if you have some research questions, then do a research year or 2 or 3, and then at the same time be on call when you know you've gained significant years of experience in that specialty. If you want to go much earlier, then you have to think why you want to go earlier. If it's just to get jobs, that's pointless. If it's just to make yourself look better CV-wise, that's also pointless, because I don't have a PhD. I'm doing one now, but I think I can say this with some degree of confidence that despite not having a PhD, I'm still more well published than the majority of people who have PhDs. So entirely depends why you want to do a research year. If you see a research year is the only way to understand research, that makes no sense, for reasons I said earlier on. If you're doing a research year because you've got a genuine shot at something which can really pique your interest, really grips you and captivates you to answer a question and achieve a goal, that's good. If it's not for that reason, then what will happen is at the end of that research year and of that PhD, you'll realise 2 things. One, you've now become backwardly incompetent in your clinical medical experiences. And secondly, you have not really achieved anything in your research year apart from a piece of paper which says, well done, you've got a PhD. But you've not really achieved goals. And then that can be very discouraging to many different people for many different reasons. And that's probably the reason why a lot of individuals who do PhDs, especially they're junior, then don't do any research after that, which makes any sense or any significant contribution to the evidence base. Okay, so it all depends on your original questions as to why you want to do a research year. It needs to be for the right reasons.
Thank you very much, Mr. Lammy. I suspect I know the answer to this next question I want to ask. But how do you go about deepening that confidence that you're asking the right sorts of research questions and that you're going about things in the right manner to answer that question?
So when you're junior, it's experience as well. That's why I took a lot of time before I got involved in lots of different projects when I was junior. I wrote letters to critiquing published manuscripts in medical school, and that was, it's not time intensive. You can read the paper, then you write a 400 or 500 word letter critiquing it. That's what I did. I then got involved in case reports because it's much more straightforward. The discussion's the most difficult part to write of a case report. We have to critique the case in the context of literature and published things, and if it's novel, makes sense, or there's significant learning points. That took me about 5 or 6 case reports later to understand that, and took time. I think I've published now 11 or 12 or 13 and supervised others on that, and then the case series got involved. So by the time I'm now with my PhD, it's a lot easier for me to understand the question that I need to ask and how to go about answering that question, but it still is a challenge each month. The goalposts do shift. If you're very junior and you've got no experience of research, it's a completely different, it's a minefield. Which is why I would emphasize again, get to know clinical medicine properly, be a good medical student, show up each day, every day, read. When you're a junior doctor, show up, work hard. In your being a doctor, in the specialties you work in, because only when you start to do that can you then understand the world you're in medically. Whereas if you have this thing in your head thinking, but I'm 3rd year, 4th year medical student, I want to do research, I want to be some big time professor, I want to do research, but you have no idea how to treat the basics of clinical medicine, you will realize you can't answer the question about research. You'll never answer simultaneously to you becoming poor at medicine, and the two combined are a lethal combination. So your motivation for research, this is just my opinion, and people will say things which are different, has got to be for the right reasons. If you want to do research because you want to be Mr. Big Shot, it's not good enough reason. If you want to do research because you're doing it purely to get a training number, that's not good enough reason either. If you're doing research because you want to understand the sequential steps of research, like how you set up a project, how do you go about delivering a project, how do you go about with ethics, how do you go about with all the different steps involved, who do you contact regarding the study, who do you get involved. If you're doing it for those reasons, what you'll find, that's a very long, laborious way, but your project will make much more sense at the end. It's more likely to get published. It's more likely to get cited. It's more likely to be read and reviewed by people in other fields by yourself as well, it's more likely to then help you answer other questions that you may have in your head. So your steps are different. It's just like it's no different to medicine. So if you want to go into medicine, if you want to be rich, we all know that's probably the wrong idea. You want to go into medicine because you're just trying to please your parents. That also makes no sense. If you go into medicine because you want to be respected by society, that's utter rubbish. If you go into medicine for the right reasons, you're more likely to stick with medicine. You're more likely to be optimistic, especially if you have very bad, challenging days. You're more likely to stick with the process. You're more likely to finish med school. You're more likely to become an inspirational doctor at the other end to encourage other people to stick with medicine. Whereas if your motivations for medicine are bad from the beginning, you'll struggle. I swear to God, man, you'll struggle. So so those questions. So when it comes to research, what you can do, and I said earlier on, is if you then email any academics near to where you work and say you just want to be involved in collecting data for some of their projects, that's quite a useful thing to do. Yep, your name may not be on the research project. You may just be mentioned in the acknowledgements, but it gives you exposure to a project and how to collect data properly for someone who knows how to do a project. And when you collect data, remember, when you collect data, you're seeing all of the basic rudiments, the nuts and bolts of what that project is. You will spot things in collecting data, sometimes even the senior author can't see. You can then have a discussion about things, and that's a good thing to do. The project does not need to be something you're interested in. It's just knowing how to collect data. And that requires you to humble yourself and accept you're just going to be a data monkey, but it's important. Okay, there's many different ways to do this. Okay, because if you think you're going to have a fixed question and answer it and move along in a seamless fashion when you've got no experience of research, that does not happen. It does not happen at all. All right.
Perfect. Thanks so much. So just to sort of maybe summarize the advice you'll be given to early medical students, late medical students. So you're saying to them, focus on being a good doctor, first of all, focus on gaining that knowledge.
Yes.
But if you want to maybe gain some experience, you can read papers, write some critiques or letters to the editors, and then get involved at the data collection stage. Would that be a fair summary of?
Yeah, I think so. Yeah, because then it gives exposure to the rudiments and read some medical statistics for you to understand. Like specificity, sensitivity, positive predictive values, all those sort of things are very important, because when you understand those aspects of basic statistics, when you read a paper, you have more of an understanding in how to critique them. And sometimes if you then notice gaps in a paper, when you write a letter to the editors or the journal authors, then you can have more of a dialogue, more of an input, and that can be quite useful as well. Hello?
Yeah, still here. Just checking to see if there are any more questions, Mr. Lammy. If not, we'll give him maybe another 4 or 5 minutes, and if no other question pops up, then we can end early, if that's okay with you. Well, thank you very, very much. This has been very useful. I hope everyone else has found it useful as well.
Yeah, it's extremely useful from my end. Thank you very much, sir.
I'm sorry, I'm not necessarily. Sorry?
Now, I was going to say, it's probably been a shock to some people, some of your advice that you might have given.
Yeah, it's very, very straightforward.
Yeah, sorry, I don't beat around the bush, because many people do push and waffle on and leave your feeling, oh, that's really nice, what a nice talker and presentation. Doesn't answer the question. How do you get involved in research? It doesn't give you any structured practical advice. And I'll say over and over again, which is probably very different to some individuals. Yes, you can knock on some people's doors and see what projects they have and get involved and collect data and do things like that, and that's good. It still may not help you ask questions. And I'm sorry, there's no shortcut to this. You need to have good experience in certain fields first before you can even think to answer or ask the right questions. I've been a neurosurgical trainee now for 8.5 years, and it's only towards the end that there's some specific questions I have, which is only through the experience I have of busy on calls, seeing so many patients, operating all the time, that only now I can go, actually, I now have some questions based on experience to ask, which are much better questions to ask than questions maybe years ago that I maybe would not have asked. I would have maybe done a PhD, already had a PhD now, but then most people with PhDs in surgical specialties, it's just a PhD, full stop. There's nothing after that. Doesn't go anywhere. They run out of steam. They get depressed. They get disillusioned because the original motivations for the research were not robust or strong enough in the first place. Okay, so I can't emphasize that enough. If you want to do research properly and get involved in the long-term game, it takes time and commitment involved. There's no shortcuts here.
So I have a sort of a personal question. For you, you seem to, before you did your PhD, you said you published, like 60 papers, and that's very productive. So I want to say, like, what takes precedence for you, the surgery or the research, the academic part?
Surgery, operating,
Okay.
I wanted to be a doctor since I was 4, neurosurgeon since I was 9. I went to medical school. If I really wanted to be a thoroughbred researcher, I would have done a PhD after my first undergraduate BSc. I would not have gone to, you've gone to medical school first and foremost to be doctors. And yes, research is important. And given a choice, I'd always choose operating. Does that mean that I don't recognize the value in research? Of course, I recognize the value in research. It's extremely important. And when you are exposed to so much human contact, it's logical that you should develop questions to help ease human suffering, pain, the burden of disease, to try and think of new ways in how to operate faster, better, quicker, smoother, to minimize complications in patients, and to operate in a more accurate, safer fashion. These things are very important. That requires some research and some exploratory ideas, but that should be predicated on the basis that you understand what you're doing when it comes to patients properly. You can take a history, thorough clinical examination, ask focused questions, request proper up-to-date imaging, and know what type of operations to do. When you've got that bolted and fixed in your head after years and years and years and years of experience, you then have more of the experience base to ask questions. Okay, so give an example. You take many people who give advice, right, about kids. Okay, you have some people who don't have kids, but they've written books. They can give you all the advice on how to parent. And lots of new parents stress themselves out buying lots of books, unbeknownst to them, are written by people who've never had kids. There's one example of this nanny. Because she was a nanny to kids from 9 till 5, she felt gave her an opinion on how kids or babies and young kids think. But she's never experienced the fatigue being a new parent is. I've been a new parent now for 6 months, and the fatigue is relentless. And unless you've experienced that fatigue, where sometimes I've not even known whether it's a Monday, Tuesday, Wednesday, Thursday, I can still operate and function at work. But when I come from home, I'm asleep by 8:30 in the evening. You're up 3-4 times a night sometimes, and then you still go to work. That tiredness challenges everything about who you are as a person when it comes to your decision making. So therefore, a book written by someone who's slept soundly at night, all night, every night, and given advice about what I should do in the evening makes absolutely no shred of sense. It can work for some people, but it's not going to work for the majority of people. Because unless you've got someone who knows what that tiredness is, and has strategies involved to help you manage your time and baby better, that person who knows what the fatigue is better placed to understand how to help you. So my point coming back to surgical specialties is I'm more likely as a surgeon to take advice from a researcher who understands my world properly than someone who's never been a surgeon, never cut into human flesh, never seen disease, death and suffering, never counselled parents grieving because their baby at 6 months or 7 months or 8 months or 6 years or 16 years is no more. I'm not going to listen to that person because they don't have the experience I've got in order to answer some of the questions we need answered to help us treat patients better. Does that make sense?
Yes, it does. Yes, it does.
Right? That's the end. That's the cookie cutter on this. That's the end result here. So yes, I would always prioritize my experiences as a doctor first, because that helps me ask the right questions to ultimately help patients.
Perfect. Thank you so much.
Just an aside to give an example like that, sometimes you get people who do research into glioblastomas. My PhD's in glioblastomas. They do the basic science. I've been to enough talks of people who've never been a doctor, never seen a patient, never seen a human being diagnosed with a malignant brain tumor, do the experiments on rice and on rats and mice about tumours they've grown in these brains, have never once spoken to a human being who's been diagnosed with this, have never once seen imaging, have never once done an operation, has never once seen a complication, has never once seen all the other aspects of the human being, counted them, broken news, seen them cry, never seen the tiredness that chemotherapy has. And these people, sometimes as the basic researchers who've never had that experience, come out with fantastic suggestions that, guess what, have never translated into anything useful that's helped a human being. Never has. As somebody once said, if you're doing your research on rats, human beings are not rats. There's a whole bank of research on rats. That obviously makes no sense because we're not rats. That in itself should tell you that whole branch of research, even though it's useful, can only go so far.
Perfect. Thank you so much, Mr. I think we're coming to the end of this session now. Anyways, if anyone has any final questions, you have 2 minutes to ask before we end things. But yeah, I just want to say a big thank you, Ms. Lamy, for giving up your time this morning, for giving some hard but very clear advice. It's been, yeah, as one person said in the chat, it's been phenomenal. So yeah, we do really appreciate it.
Thank you very much, sir.
No problem. All right, guys. Take care, Tommy. Bye.
All right, bye. Thank you very much, sir.
Bye.
Take care, Hillary.
Hope the fatigue improves.
It won't. It's lifelong.
All
right. Bye.
Bye.
All right, Toma, nice one. And I wish you success with the. I don't know what stage you're in now.
Yeah,
I you were doing interviews. Oh, okay.
Yeah.
I pray it clicks.
Thank you very much. Right, take it. Bye. Thank you, everyone who's stayed and participated so far as well. Hope it's been useful for you all. Okay. Bye.